we have an amazing speaker, Dr. Jean-Claude Tardif, who will be speaking about the anti-inflammatory therapy with colchicine for prevention of atherothrombotic events. It's a real pleasure to have Dr. Tardif here with us today. He's the director of the research center at the Montreal Heart Institute and a professor of medicine at the University of Montreal. Dr. Tardif holds the Canada Research Chair in Personalized Medicine and the University of Montreal Endowed Research Chair in Atherosclerosis. He's also the scientific director of the Montreal Health Innovations Coordinating Center. Dr. Tardif, in case you don't know him, he has over 750 scientific articles. He's also the first author for the COLCOT trial that was published in New England Journal of Medicine in 2019, but he has about 17 New England Journal of Medicine papers. He has also won multiple awards, including the Research Achievement Award from the Canadian Cardiovascular Society, the Distinguished Lecturer Award of the Canadian Institutes of Health Research, and multiple other awards. Because of his accomplishments, Dr. Tardif was named as a Fellow of the Canadian Academy of Health Sciences and a Fellow of the Royal Society of Canada, and was inducted in the Order of Canada, the highest distinction in the country. As someone that does prevention, I've read a lot of your papers, and it's a great honor to have you here with us. Thank you.
Oh, thank you so much. I am really happy and honored to be with you today. I'm going to take 40 or 45 minutes to present the data on inflammation reduction therapy for prevention of atherothrombotic events, and hopefully we'll have enough time for comments and questions. So just one summary slide and cartoon to basically allow me to say that there's a wealth of data showing the link between inflammation and immunity in atherosclerosis. We know that atherosclerosis is an inflammatory disease, one that involves a number of cytokines and chemokines, and a number of key cell types, including macrophages, different types of lymphocytes, as well as neutrophils. So we know that from preclinical data that dates back for at least 30 years. And then the question is, how is this relevant for our patients? How is this relevant clinically? And so allow me to start with what I believe is an important paper that Paul Ritker from Boston published in the Lancet in March of this year, where I'm not going to go all the details, but you can focus on the right part of the slide, where he took 3 large studies totaling 31,000 patients, all treated with statins. And the question there was posed, once you are treated with a statin, what is going to be associated more closely with future cardiovascular events 3 years down the line? Is it cholesterol, in white here, LDL cholesterol, or is it an inflammatory biomarker, high sensitivity C-reactive protein? And so on the right part of the slide, again, you see the association between major adverse cardiovascular events and LDL cholesterol in white and CRP in black. And you see that in these 31,000 patients, inflammation, as measured by CRP, was predictive of events, or predicted events better than LDL cholesterol did once a patient was on statin. So this was for a collection of major adverse cardiovascular events. If you then turn to cardiovascular death, the relationship is even stronger. You see again for CV death going from quartile 1 to quartile 4. Again, on the right side of the slide, you see that inflammation predicted better future cardiovascular deaths than LDL cholesterol did in these 31,000 patients treated with a statin. It's just to say that inflammation matters in our patients. So Paul Ritker also dichotomized these 31,000 patients into whether or not they had controlled or uncontrolled LDL cholesterol. He used there a cutoff value of 70 milligrams per deciliter. And controlled or uncontrolled inflammation, and he used a cutoff value of CRP of 2 milligrams per liter. If you look at the two bars on the left, you can observe that if you do not have any evidence of ongoing systemic inflammation, your CRP is below 2, it almost does not matter where is your LDL cholesterol once you're treated with a statin. So if your CRP is below 2, the hazard ratio for cardiovascular death is not different whether your LDL cholesterol is below or above 70. But then if you compare the two left bars with the third bar, once your CRP is above 2 milligrams per liter, even if your LDL cholesterol is low, you see that major increase in risk of cardiovascular death. So once again, this is not a be-all and end-all, but it is certainly strongly suggestive that inflammation matters in our patients with atherosclerotic cardiovascular disease or diabetes, because these three studies targeted those patients. So then the next logical question is, well, if inflammation matters in our patients, what if we were to lower inflammation? So let me just start with one preclinical study that we published a few years back. We used one powerful anti-inflammatory agent that you use all the time for various diseases, colchicine, whether you use it for gout or pericarditis. And so I'm not going to go into the details of that study using a standard rabbit model, but suffice it to say that rabbits who were treated with colchicine had reductions in plaque inflammation, in arterial wall fibrosis, importantly, less outward negative vascular remodeling or deleterious vascular remodeling, and obviously less monocyte activation. So it's nice to see a preclinical study, but there's a long way from obviously rabbits to men or women. And then the question is, well, what about inflammation reduction in human beings? So this is a paper we published a few years ago with Peter Libby from Boston. It was just a summary of the study at the time that had been conducted. I will not spend too much time on this. I would just attract your attention to line number 2. I want to give credit to Paul Ritker, who really conducted the first landmark study, CANTOS, showing that selective inflammation reduction with a monoclonal antibody to interleukin-1 beta, canakinumab, in 10,000 patients resulted in a reduction of future cardiovascular events by approximately 15%, 1.5. Interestingly, canakinumab had no effect on lipid lowering. So that was a positive study. The problem is, as you know, canakinumab requires injections. Canakinumab is extremely expensive, I believe more than $100,000 per year. And in that study, there was a small but significant increase in the incidence of septic shock. So that was just my introduction, just to support the work that we and others have done with an orally administered, powerful anti-inflammatory agent called colchicine. To this day, colchicine is known to only bind to one protein, which is called tubulin, which is the structural protein the study that have been conducted. There have been 2 large studies of colchicine in patients with established atherosclerotic disease. The first one was COLCOT that we conducted and published in 2019. And the second one was LODOCO2. So I'm going to come back to that in a minute. Well, let me just walk you through what was COLCOT and its results. So COLCOT, we recruited 4,700 patients within 30 days after myocardial infarction. These patients, as you can imagine, received a statin, in the vast majority of patients, 2 antiplatelet agents. and then were treated according to national guidelines, and percutaneous coronary intervention, or PCI, was completed if deemed necessary by the treating physician. And then patients were randomly assigned to receive low-dose colchicine, 0.5 milligrams per day, or a placebo. So 0.5 milligrams per day, a dose that is a bit lower than what you are used to use in the US. Just to give you a feel for the type of patients we had in COLCOT, so again, 4,700 patients, mean age 61 years, unfortunately a minority of women. Hypertension was present in half of the patients, and diabetes in 20% of the patients. If you look at the last 5 lines of that slide, only a minority of patients had prior evidence of cardiovascular disease before their index myocardial infarction that led them to enter COLCOT. Importantly, a few additional characteristics. The mean interval between myocardial infarction and randomization was 13 days, so 2 weeks. PCI was performed in the vast majority of patients, 93%. And in terms of standard of care, it was excellent. Aspirin being used in 99% of patients, a second antiplatelet agent in 98% of patients, and a statin in 99% of patients. So excellent standard of care, and therefore, whatever result we show is certainly relevant on top of good standard of care. So here is the primary result from COLCOT for the primary efficacy endpoint, the composite of cardiovascular death, cardiac arrest, myocardial infarction, stroke, or urgent hospitalization for angina requiring revascularization, and obviously presented in the standard time to first event. You see that the addition of colchicine 0.5 milligrams per day resulted in a relative risk reduction of 23% compared to placebo, with a p-value of 0.02. And you see here that the Kaplan-Meier curves diverged very early in favor of inflammation reduction with colchicine compared to placebo. Now, with a bit more granularity, so the line that is underlined shows you again the relative risk reduction of 23%, shows you the absolute risk reduction of 1.6%. And then for more granularity, you have the 5 components of the primary endpoint. We were not obviously powered for any individual component of the primary endpoint, but if you just look at the point estimate for CV death, 0.84, cardiac arrest, 0.83, myocardial infarction, 0.91, stroke, 0.26, and urgent hospitalization for angina requiring revasc, 0.50, which means that the effect of colchicine on each of the 5 components into this favorable significant effect on the composite primary endpoint. But the effect in COLCOT was more marked on stroke and urgent hospitalization for angina requiring revasc. We will come back to the effect of colchicine on myocardial infarction when I go back to the second large study, LODOCO 2, and all of the meta-analyses, and you'll see a more marked effect on myocardial infarction. I would attract your attention towards the bottom of the slide, the number of deaths from all causes, 43 in the colchicine arm, 44 in the placebo group. Now, we had pre-specified, and all of this was in our New England Journal paper 2019, that we would also be looking at the so-called per protocol analysis, basically excluding patients with major protocol deviations, including those who were not taking their medication. And sure enough, when we did that, the effect of colchicine was even more marked, a 29% relative risk reduction with a p-value of 0.004 when people were taking their medication. And again, with more granularity, I'm not going to read that aloud for you. You see the same kind of effects, but here you see the effect on myocardial infarction was more marked than in the intent to treat analysis. Now, all of that up to now was presenting this in the standard time to first event. Obviously, from the patient perspective, the healthcare system perspective, the payer's perspective, it is not only the first event that matters. I'm sure we all see these frequent flyers that come in and out of the hospital with, repeated events. So we had pre-specified in COLCOT that we would perform a so-called recurrent event analysis, not only looking at the first event, but this time looking at both the first and subsequent events. And so I'm not going to go through all of the pre-specified statistical analysis models that we had. In red, you see the pre-specified modality of choice that we had declared, which was the negative binomial model. And when we did that analysis, colchicine yielded a 34% reduction in first and recurrent primary endpoint events compared to placebo. And I would submit to you, I know of no other drug that we have in our armamentarium that yields a 34% reduction in cardiovascular events on top of high-dose statins and 2 antiplatelet agents. So turning to safety and tolerability, most of us, when we think about colchicine, we often think about gastrointestinal side effects and diarrhea. So I just wanted to put that in front of you. When we looked, and again, this is colchicine 0.5 milligrams, an extended release for adverse event in the 4,700 patients followed for 2 years in COLCOT. The incidence was 9.7% with colchicine, 8.9% with placebo. The difference was not statistically significant. We did see a small but significant increase in the incidence of nausea in 1.8% of patients in the colchicine group and 1.0% of patients in the placebo arm. Then the final 2 points, because, when as clinicians, we know when we give medications to help our patients, we often pay a price. When we give antithrombotic agents, anticoagulants, patients for several diseases have better outcomes but bleed more. So then the question was, when you start affecting inflammation and immunity, are you going to pay a price, especially in terms of the emergence of infections? And so, especially because of what happened in the CANTOS trial with a different drug, canakinumab, we look closely at the development of infections in COLCOT. Again, 4,700 patients followed for 2 years. We did see in COLCOT a small but significant increase in incidence of pneumonia, 0.9% in the colchicine group, 0.4% in the placebo group. However, in contrast to what was observed with canakinumab in CANTOS, no difference in septic shock, 2 septic shocks in both study arms. So basically a very reassuring safety profile for low-dose colchicine. Just before closing this chapter, just want to add one additional analysis that we then published after the initial paper in New England Journal. This a subgroup analysis, and I want to acknowledge my young colleague, Nadia Abou-Abdallawi. And we published that paper in European Heart Journal 2020. When you see here underlined TTI, it stands for time to treatment initiation. So what it means, this is the interval between the myocardial infarction and the time at which the patients were randomized to receive either colchicine or placebo. So all that is here is the subgroup analysis of patients who were randomized before they were discharged from hospital. That's all that is. But the hypothesis was, if atherosclerosis is an inflammatory disease, And if myocardial infarction, an acute myocardial infarction, is an exacerbation of a chronic inflammatory disease, could we hope for an even better result if we were to start colchicine even earlier? Again, this should be taken with a grain of salt. This is a subgroup analysis, but published in an excellent journal. And you see that the benefit of starting colchicine after an MI before patients are discharged was even greater, a 48% relative risk reduction. And you actually see that the curves diverged before a month in favor of inflammation reduction. So we were quite happy to have performed a large study, followed for 2 years, with a drug that we can actually give as clinicians, that has been known for 150 years. We were very excited when there was a second study that was published, the low-dose 2 study, or low-dose colchicine 2 study, that was conducted in Australia and the Netherlands, led by a friend of mine, Mark Nydorf. Let me just walk you through this low-dose 2 study. I believe that it is complementing our COLCOT study very well. Again, I remind you, COLCOT, 4,700 patients within 30 days post-MI, followed for 2 years. Low-dose 2, 5,500 patients with stable coronary artery disease. Again, randomized to receive colchicine 0.5 milligrams per day or placebo. Just very briefly, you see that the patients were a bit older, 60 years on average. Hypertension, half of the patients, as was the case in COLCOT. Diabetes, 18-19% of patients, as was the case in COLCOT. And 84% of patients had a prior event, a prior ACS event, but by definition, more than 6 months before randomization. Standard of care was very good, a bit different than COLCOT that was conducted post-MI. So that's why you see the percentage of use of DAPT, dual antiplatelet therapy, was much lower in low-dose 2, but you see that statins were used in 94% of patients. Primary endpoint, almost identical to COLCOT, a spectacular result, a 31% relative risk reduction in favor of colchicine compared to placebo. On the primary endpoint, the composite of CV death, MI, stroke, or ischemia-driven coronary revascularization. And again, you see the curves diverging in favor of colchicine very rapidly in a matter of less than 6 months. Turning to the key secondary event, key secondary endpoint, the composite of cardiovascular death, myocardial infarction, or ischemic stroke, a 28% reduction with colchicine compared to placebo, with a p-value of 0.007. And then a number of ranked secondary endpoints. I'm not going to read all of that for you, but I would like to point out lines number 3 and 5. Line number 3, the composite of cardiovascular death or myocardial infarction, which was reduced by 29% with colchicine compared to placebo, p-value of 0.01. And line number 5, all fatal or non-fatal myocardial infarction with a p-value of 0.01 and a 30% reduction. There was a strong trend as well for a reduction in ischemic stroke, but the numbers were small. A 34% relative risk reduction that was not statistically significant because the number of events was too small. So it is not entirely clear why in COLCOT the effect was more marked in stroke than MI, and in low-dose 2 the effect is more marked on MI than stroke. But you will see that, in my opinion, it does not really matter, because you will see in a minute all of the meta-analyses that provide a very robust and strong signal. Now, if you look at the two lines at the bottom, I told you in COLCOT, the number of all-cause deaths were identical in both study arms. Here, 73 in the colchicine arm 60 in the placebo arm, so that a neutral effect on mortality. You'll see in the meta-analyses, this is a summation of a non-significant trend for reduced CV mortality and a non-significant trend for increase in non-CV mortality, that is in the LODOCO-2 study, with no imbalance in diagnoses of new cancer, infections, and pneumonias. So let me just turn now, in the interest of time, how to put all of those data together. There have been, to my knowledge, at least 5 published meta-analyses of colchicine studies in coronary artery disease. They basically all show pretty much the same thing, a very consistent message. Just allow me to use our meta-analysis in this case. I want to acknowledge my young PhD colleague, Michelle Samuel, who performed that analysis. So we, for the primary endpoint here in that meta-analysis of using all studies that were available, for the primary composite endpoint, this was the composite of CV mortality, MI, stroke, or urgent coronary revascularization. You see the red lozenge, and you see that the hazard ratio was 0.68, meaning a 32% reduction in that important primary composite endpoint with colchicine compared to placebo. If you just look at just to the right side, at the upper bound of the 95% confidence interval, it is 0.81, which means that the worst case would be a benefit of 19% of colchicine over standard of care. So now I will go through the next 4 slides very quickly. It will be the same meta-analysis. So your eye can just look at the second line of the title, and then you can go to the red lozenge and you'll see the point estimate for the effect. So just look at the second line of the title, you know what we're talking about. This is the same study. So how about myocardial infarction? A 38% relative risk reduction with colchicine compared to placebo, which was highly significant and very large. I don't think we have a therapy that reduces MIs by 38%. How about strokes? A 62% relative risk reduction, which was highly significant. And urgent coronary revascularization, a 44% relative risk reduction with colchicine compared to placebo. Just before closing that chapter, how about the composite of the so-called triple hard endpoint, CV death, MI, and stroke, a 22% relative risk reduction with colchicine compared to placebo. Now, how about, so up to now, I hope I've convinced you that there's no doubt that colchicine reduces robustly and importantly, non-fatal events. How about all-cause mortality? So you have it here from the same meta-analysis. First, all-cause mortality, you see that the risk ratio is 1.04. So basically, again, what you have with colchicine is a null effect on all-cause mortality, which is a summation, as I said earlier, of a trend, a non-significant trend for reduced cardiovascular mortality after only 2 years, by the way, and a non-significant trend for increase in non-CV mortality. At the end of the day, in my opinion, what matters is whether you're dead or alive, not the cause of the death, and all-cause mortality was neutral. All of that with no effect on infections, pneumonias, hospitalizations for GI events, or new diagnoses of cancers. And for those who might be interested, we have reviewed that in great details in a paper invited by the Circulation editors. So all of these data led, and this was very exciting for us, first before the FDA just gave their evaluation, Health Canada first approved low-dose colchicine, as you see here, for the reduction of atherothrombotic events in adult patients with existing coronary artery disease, in addition, obviously, to standard therapy, including LDL-C lowering. And these are not my words. These are in quotation marks from Health Canada. Next slide will be the FDA label. And then the next point is also a quote from Health Canada. And this is important. Colchicine is contraindicated in patients receiving concomitantly a strong PGP inhibitor or strong CYP3A4 inhibitor. The classical example is clarithromycin, Biaxin, which is an antibiotic that I personally do not use. Importantly, there is no problem of combining azithromycin with colchicine. The next line is probably the most important in these words of caution. Colchicine should not be given in patients with severe renal impairment as defined by a GFR less than 30. At the bottom of this slide, this is just my comment, because I still sometimes hear people say, clinicians say, oh, I thought that we're not allowed to combine colchicine with high-dose statins. This is incorrect. Proof being that if you count COLCOT, 4,700 patients, LODOCO2, 5,500 patients, so that's more than 10,000 patients followed for 2 years. 99% of patients receive a statin in COLCOT, 94% of patients receive a statin in LODOCO2, and there was no issue combining low-dose colchicine with a statin. So what about the FDA? Well, we were very happy when the FDA in June 2023 approved for the first time the first anti-inflammatory agent for cardiovascular prevention. So here is the FDA label. Colchicine 0.5 milligrams once daily is indicated to reduce the risk of myocardial infarction, stroke, coronary revascularization, and CV death in adult patients with established atherosclerotic disease or with multiple risk factors for cardiovascular disease. They also came back with the same guidance. Concurrent use of strong CYP3A4 inhibitor or PGP inhibitor with colchicine is contraindicated, including in patients with renal impairment. And finally, the FDA also stated colchicine is contraindicated in patients with pre-existing blood dyscrasias, renal failure, or severe hepatic impairment. So what about guidelines? Well, the first 2 points here, I just summarized, Health Canada and FDA. There have been 2 important documents issued within the last 2 or 3 months. In August, the European Society of Cardiology issued their guidance and included low-dose colchicine as a class 2B indication. And the ACC, I'm sure you're aware of this, also recommended colchicine. And the recommendation is, as you can see here, in patients with chronic coronary disease, the addition of colchicine for secondary prevention may be considered to reduce recurrent ESCVD events. I would like to tell you that this is a class A1 indication. I think that they will come when people hear more consistently about these data. So here it says conclusion, but this is not my last slide. Let me just read with you what we wrote about 2 years ago in GACC, when the editors of GACC asked us to write an editorial. I think these words still hold true. In conclusion, low-dose colchicine reduces the risk of ischemic cardiovascular events on a background of excellent standard of care, irrespective of whether the patient has had a myocardial infarction or presents with stable CAD. In light of the positive results from LODOCO2, COLCOT, and meta-analyses, its good tolerability profile and cost effectiveness, inflammation reduction with low-dose colchicine should be considered to treat patients with coronary disease in the absence of severe renal dysfunction. So 2 points in addition. I wrote the words cost effectiveness. I haven't shown you these data on purpose. Obviously, in my neck of the woods in Montreal, colchicine costs 27 cents. But we have published in a European Heart Journal subjournals the cost effectiveness analysis, and what we have shown is that colchicine is economically dominant And so economically dominant means it's not costing you X thousands of dollars per event saved. Anytime you prescribe colchicine, you save dollars to the healthcare system. And so it remains economically dominant up to $1 per day, and it remains cost effective up to $4 a day. And the other point is, I did write inflammation reduction with colchicine should be considered. I'm not saying that we should treat all patients with CAD, but I think it now should be the time to start considering inflammation reduction as a pillar of therapy. Let me just, before closing, address directly a couple of points that I hear from time to time. And I suspect some of you may have comments or questions about this for me. Sometimes I hear, well, JC, 23% relative risk reduction or 31% in low-dose code 2. Is that really impressive? Well, I'm certainly open to have that debate, but here is a figure from a very nice paper from Paul Ritker and Valentin Fuster in GACC, putting side by side different lipid-lowering approaches on top of statin therapy versus inflammation reduction. All these papers have been published in New England Journal. Certainly, this is certainly not to say anything bad about PCSK9 inhibitors. They're great drugs. I use them in my genetic lipid clinic. But I think it is interesting to just see that both in FOURIER and Odyssey, the primary endpoint was reduced by 15%. So I have no issue someone coming to me and say, well, 23% is not quote unquote spectacular. Let's have the debate. I happen to think it is spectacular. On average, a 27% reduction. But I just would like the different approaches to be put on the same scale. And you have it side by side. Then sometimes I hear, well, it's not only relative risk reduction that matters. How about absolute risk reduction? Well, let's have that debate. And you have it on the right part of the slide. So if someone tells me, well, a absolute risk reduction of 1.5% is not terribly exciting, well, my response would be, well, you see, this is only after 2 years of therapy with an inexpensive drug. And you see that when you combine in the meta-analysis, it's about an absolute risk reduction of 2%. And again, I just want to compare that with the 1.5% absolute risk reduction with PCSK9 inhibitors. So I just want the different approaches to be put on the same scale. And then the final point, sometimes I hear, well, you know, that's all very nice and good, but you don't lower therapy, you don't lower mortality. Well, again, I just want the different approaches to be on the same scale. First of all, I'm surprised when some people say that, because actually my patients are more concerned about suffering from a stroke or another bad event. That's their first concern. So even if you don't lower mortality, after only 2 years, by the way, of follow-up, I think it is highly relevant to reduce non-fatal cardiovascular events. And second, I have no problem for someone coming and tell me, well, I'm less excited by a drug that's not lowering mortality after 2 years. And then I would say, well, fine. Then I hope you're not prescribing PCSK9 inhibitors, because they too did not lower mortality after 2 years of therapy. So what does that mean in terms of implications for practice? I will be done in 2 or 3 minutes now. So I've gone full circle. I started with Paul Ritker's slides published in the Lancet. And I just want to use Dr. Ritker's words when he presented simultaneously at ACC on the day that he published in the Lancet. And so should clinicians elect to use a second lipid-lowering agent or choose instead to use an anti-inflammatory agent, with the data strongly showing that what is predictive of future events once you're treated with a statin is much more inflammation than LDL cholesterol, I would submit to you that it would make a lot of sense to consider adding colchicine to patients with atherosclerotic cardiovascular disease. Again, it does not mean to oppose lipid lowering with inflammation reduction therapy. It means combining these approaches. So just before closing, the Lancet editors asked me to write an editorial when Paul Ridker published that wonderful and important paper. And I just want to close with that here. I sometimes hear clinicians say, well, you know, my patients are complaining that they're taking too many drugs, and why add yet another drug? And so this is the issue of polypharmacy. I am struck when people say that, because when we treat patients with heart failure, most of us would be considered bad physicians, bad healthcare professionals, if we were not to use the standard pillars of therapy, a beta blocker, an angiotensin receptor, a RAS inhibitor rather, Entresto, SGLT1 inhibitors. And so I'm surprised that we've all adopted this concept of systematic use of multifaceted treatment pillars in heart failure. And when comes the time to treat a disease that actually kills more people on the world stage, atherosclerotic cardiovascular disease, we are more concerned then about polypharmacy. So I believe that if this game is about preventing MIs, strokes, I think that we should, as I wrote at the bottom of the slide here, I think that we should no longer consider intensive lipid lowering and inflammation reduction as mutually exclusive, but rather as complementary approaches in patients with ASCVD who are already receiving statin therapy. So again, just before closing, all of that was about secondary cardiovascular prevention. So what about primary prevention? And I'll leave you with that thought. We've just launched a few months ago a very large primary prevention inflammation reduction trial called the COLCOT T2D trial, which, as the name implies, is a study of 10,000 patients with type 2 diabetes, but this time without known coronary artery disease. And we will try to demonstrate that early inflammation reduction therapy with colchicine will prevent MIs, strokes, other bad cardiovascular outcomes. And we will also be evaluating serially cognitive function and dementia in these patients. And this time we will follow them on average for 4 years. So I thank you very much for your attention. It has been an honor to be presenting for you, in front of you. And I hope that this was of interest to you. And I'm looking forward to your questions and comments. Thank you very much.
Thank you very much, Dr. Tardif. That was an amazing lecture. And like you're saying, I think we learned a lot, and this could be implemented directly on patient care. Please put your questions in the Q&A. I'll start with one question with two parts. Should we be checking CRP in secondary prevention before we decide to use colchicine? That's part one. And the second one, we are doing a lot of imaging now with CT in particular, and we see a lot of non-obstructive plaque. Do you think in these patients CRP will make the decision, or imaging modalities for inflammation like epicardial adipose tissue or PCAT analysis or some imaging will do it?
Oh, this is a great question in two parts. So thank you very much. So I will tell you what I think, and obviously this question is discussed and debated all the time, and I'm sure most of you have listened to those debates. So I'm going to tell you what I think, which is very similar to what Mark Neidorf, who led LODOCO 2, thinks. So in both COLCOT and LODOCO 2, we did not measure CRP at baseline to allow patients to get in the trial. In COLCOT, there was a very simple reason for doing that. We recruited patients within 2 weeks after MIs, and there's a bump of CRP at the time of MI, so whatever you do afterwards is going to come down. So we said it's really not relevant to measure CRP very early after an MI. So that's why we did not do it. There was a very simple reason for that as well. Obviously, when a drug costs 25 cents, this is not supported by the pharmaceutical industry. And so our funds were limited, and we wanted to provide a high quality answer to the important clinical question, are we preventing cardiovascular events? So we don't have, and it's the same thing for low-dose CO2. Now, to get to the answer to your question, in my opinion, I do not use systematically CRP to determine who should be receiving inflammation reduction therapy, because we did not use it in COLCOT and low-dose CO2. Now, I would certainly not say that someone would decide to do that would be bad practice. And I would say, given that colchicine is still not being used, at least if people use it in patients with high CRP, I would call that a very good start. So that's what I think. Now, I would tell you that Paul Ritker has a different position. He's obviously a strong proponent of the use of colchicine, but he is saying that he's giving his patients with CRP above 2 or above, colchicine, and that's what he wrote in this wonderful review in JACC in August. So I guess I'm using it, I'm using colchicine more liberally, but if someone wants to restrict it to patients with an HS-CRP value of 2 or above, that would make a lot of sense as well. As far as imaging is concerned, I too, Leandro, is struck by the fact, so I run at my institute, the Montreal Heart Institute, the lipid clinic, the genetic lipid clinic. So I just, as one individual, I follow 400 patients with FH, for example. And so I use systematically angio-CT in these patients. And I'm just amazed that I think you alluded to, at the horrors we see in patients that have no symptoms, and the extent and severity of CAD in patients, for example, with familial hypercholesterolemia. And so to me, when I see a patient like this, it means that that patient is at high risk. And so a patient that has extensive coronary artery disease, in my opinion, has the disease and should be treated aggressively with the different pillars that we have at our disposal, including inflammation reduction, in my opinion.
Thank you very much. Thank you very much. I agree with you. We have multiple questions. We'll try to go through all of them. We have here one from Aldo Scanone that I know he's very interested in inflammation and colchicine. And he says that data suggests an unparalleled benefit. What is to blame for the suboptimal adoption of colchicine in CAD post-MI patients in the community?
Yeah, thank you for that comment. Well, I'll tell you my take on it, and I'm not being facetious, because I too am wondering what is happening. I'm old enough, and probably older than several of you watching this. I'm old enough to have been in the room when the first large statin study came out. And that was the 4S trial, 4,444 patients. And I have to admit, I think that was a spectacular trial. And the adoption was not overnight, right? People needed to be trained, needed to be convinced. And it was after a second trial came out that then there was really the paradigm shift. Now that we have low-dose CO2 following COLCOT, we have 2 large trials showing the same thing. I think we should start changing our practice. I think that one of the reasons why adoption is not there, and I'm not the only one who thinks that, certainly Paul Ritker is convinced about this, there's no support from industry. So, you hear about SGLT2 inhibitor, and I'm not badmouthing any classes of agents, I use them. But you hear about SGLT2 inhibitors, GLP-1 receptor agonists, like every day of the week. You go to the AHA or ESC, your hotel card has the logo of a SGLT2 inhibitor. And there are probably like only 4 clowns, including me, talking about colchicine. So I think it is a factor. We're not talking about this because we're not bombarded by an industry. And I'm not bad-mouthing any drug, but I'm just addressing the issue head on. And then I think this issue of mortality has been used by some people and say, what about this cloud and blah, blah, blah. Well, in my opinion, there's no cloud. I mean, the picture is clear. Colchicine yields a large reduction in non-fatal events and a neutral effect on mortality after 2 years. That's the message. Now, there's a trend for lower CV mortality, a trend for non-CV mortality, but at the end of the day, they're the same number of deaths in both arms. So I think that lowering dramatically strokes and MIs and revas should be relevant. And I think the more we have debates like this, the more people will adopt it. And so I'm confident that things will change. And by the way, obviously there are things that need to remain confidential, but I'm aware of several companies that are developing several anti-inflammatory agents for heart disease. What makes me a bit sad is that now you have a pill, like in my neck of the woods, it's 27 cents a day, and people are wondering whether they should adopt. And then when there are drugs that are going to come out that cost $8,000 a year, but then you'll have a barrage of presentations and people will adopt it. So I hope that people will adopt it sooner. I hope you're using colchicine all the time for acute pericarditis. I hope you're using it all the time for gout. And so I hope that things will change over the next months. Sorry for the long monologue, Leandro.
No, that was great. I think this physician inertia is well described, and it's something that takes a lot of investment to fight and change. And so, yeah, so hopefully, lectures like this, and that's one of the reasons why we started. It's not funded by any pharma, and you can reach anyone for free. So there were some questions by Dr. Travin and Dr. Scanone about these non-cardiac deaths, but I think you answered that already. So there's a question by Nicola Tarantino, an EP attending here with us. He says, thank you for the clear presentation. We know that colchicine reduces the post-op risk of atrial fibrillation after cardiac surgery. He says, do you see any role for early rhythm control along with regular antiarrhythmic drugs? Thank you.
Okay, so there have been some data suggesting indeed that colchicine can reduce the risk of atrial fibrillation. These data are not definitive. There was a paper presented at the ESC last month and published in what journal was it? It's in the Lancet. It's called the CUP-AF trial that failed to show benefits of colchicine in that setting, patients undergoing thoracic surgery, but there were multiple issues, methodological issues of that study. So to make a long story short, there are several ongoing studies of colchicine right now in patients undergoing ablation of pulmonary veins and so forth. We're certainly conducting our own, but at this stage, I don't think you should be using it systematically.
Thank you very much. And there's another question, so maybe we can comment one more time on this issue with the neutral mortality, but decreasing cardiovascular mortality and the possible causes of the non-cardiovascular death. You say we shouldn't worry about it? Is it possible to analyze or dig into these different issues?
Yeah, so several things. First of all, and you might criticize us for that, and would be fine, accept that. So we did the mean duration of follow-up was 2 years. There's a reason for that, and to be very transparent, there was a financial aspect to this. If we had $50 million from Pfizer or whatever company, we would have followed these patients for 2 more years. I think that most drugs that lower non-fatal events, important non-fatal events, should be expected down the road if you follow patients long enough to translate into reduced CV mortality. All we had here was a trend for reduce CV mortality. Now let's turn to non-CV mortality. There was actually a paper I did not present today from Mark Neidorf and Lodoco 2. I think it was published in the International Journal of Cardiology. They tried to understand what was there a trend of some sort, and there was nothing. There was no effect on cancers, infections, any disease, renal disease, liver disease, suicides. There was nothing that was obvious. It appears, there was no pattern. So there doesn't seem to be anything of concern. And at the end of the day, in my opinion, what matters is the fact that the overall mortality, all-cause mortality rate is neutral. So I think that part is reassuring.
Thank you very much. Going into that side effects, still a question from Dr. Jay Chuda, one of our cardiologists. Is there any concern about the infections, in particular in those with diabetes?
Yeah, so we had that trend, not that trend, we observed a bit more pneumonia. And by the way, these were these patients were not hospitalized for that, but or in a minority of cases. So we saw a bit more pneumonias with colchicine and placebo in COLCOT. They did not see it in Lodoco 2. And when all of these data were put in a meta-analysis, there was nothing. So that to me is very reassuring. And so, no, I'm not too concerned. In terms of patients with diabetes, you're absolutely right that these patients are at risk of more complications from severe infections. So we obviously in COLCOT T2D will have these 10,000 patients with type 2 diabetes. There is a data safety monitoring board monitoring the study. So if there was anything, they will pick it up and would inform us. But I'm not particularly concerned, no.
Thank you. And I think just to finish, we have a great question to finish with Rob Osfeld, our Director of Preventive Cardiology. He says, thank you for the wonderful talk. So after this lecture, people want to use colchicine. What's the availability of colchicine 0.5 in the US? And would you advise 0.6 versus 0.5? Do you think it's the same for CAD treatment? Okay, good. So colchicine 0.5 has been introduced last month, I believe, in the US. The drug is called Lodoco. So it's easy. It's the same name as one of the two studies for low-dose colchicine. So it is available. But I understand, reading between the lines, your question is not that. Your question is there a difference between 0.5 and 0.6? In terms of efficacy, I think that probably it would not make a huge difference to use 0.5 or 0.6. In terms of tolerability and safety, there might be a difference. I can tell you I've used colchicine extensively. I've had patients before the 0.5 milligram dosage was introduced in Canada. I had some patients who did not tolerate 0.6 and for some reason even did not tolerate 0.6 every other day. And when I put them on that new extended release formulation of 0.5, these patients tolerated the 0.5 without any problem. So there's that possibility. And then more importantly, obviously there's part of colchicine excretion that is from the kidneys. And because we're all dealing with, often old patients for which there's some degree of compromise of the renal function or liver function, there is a difference in terms of 0.5 versus 0.6. There's been a nice paper, a pharmacokinetic paper, showing that when you use 0.5 instead of 0.6, the likelihood in patients with moderate renal dysfunction, the likelihood that you might be outside of the therapeutic window, above the therapeutic window, is higher with 0.6 than 0.5. Whereas with 0.5, you're always within the therapeutic window, unless a patient has severe renal disease. So, and sometimes I hear, and that's my final comment, sometimes I hear, well, really, what's the difference between 0.5 and 0.6, 0.1? Why should it matter? Well, I can again say I'm old enough, and I understand some of you cardiologists may be a lot younger than I am and might have never used digoxin in their lives. But for digoxin, in the past that we were using, I know some of the more older cardiologists will know, going from 0.125 to 0.0625 in an old person
could make a lot of difference in terms of less nausea or anything. That's less than 0.1 difference. So there is a difference between colchicine 0.5 and 0.6. If it's easier for you to get your hands on 0.6, then might as well use it. But if it is possible very soon to use 0.5, I would recommend to lean more towards 0.5, if possible.
Thank you very much. I think we can end with that. It was an amazing lecture, and hopefully we'll see you in person, maybe AHA or ACC.
I would love that. It was a great honor to be with you, and thank you for the invitation. Looking forward to see you at AHA.
Okay, bye-bye.